All right, I think we'll go ahead and get started. Good morning. I'm Lisa Chamberlain, Associate Chair of Policy and Community Engagement, and very excited to welcome you all this Friday morning to our Pediatric Grand Rounds. Very excited about our session today, which Dr. Patel will introduce in just a moment. As our routine, please do text in the code that you see here to this number to get your CME and confirm your attendance. As always, that code will be in the chat at any time. You can reference it throughout the talk to be able to claim your credit. Some upcoming grand rounds we're very excited about. Next week, we'll be hearing about the pediatric medical device innovation. Kids aren't just little adults, as we know, to be given by our own Drs. Forch and Wall. So looking forward to that. Followed the next week by Dr. Hart Cooper. Got great energy, you can tell from his picture, talking about virtual PrEP, expanding adolescent and young adult access to HIV prevention. So that should be a great update for all of us. And want to give a shout out to our COVID in Children seminar series. Next one will be on March 11th. These fall on Thursdays at noontime, so you can grab your lunch and get up to date on everything COVID for kids. Lots going on with the vaccines and testing and everything. So please do tune in to hear from our own Drs. Maldonado and Matthew. Also CME available for that as well. So look forward to having you all join us for that. Next slide. Want to draw everyone's attention to our 12th annual Pediatric Research Retreat. Will be happening over 3 half days, Monday, April 19th, Wednesday, the 21st in the afternoon, and then Thursday, the 22nd in the morning. So you can see kind of the breakdown of the time there. And this 3-day virtual event will feature many folks from our department. Next slide. You can see the breakdown of the speakers here, everything from our most senior faculty to many of our trainees, including residents, fellows, postdocs, medical students. So should be a real celebration of innovation and research. So please do take the time to block some of those half days so that you can join us and catch many of those highlights. So at this point, I'd like to turn things over to Dr. Patel, who's going to introduce our speaker, Dr. McCrindle. Dr. Patel.
Thank you, Lisa. The Division of Pediatric Cardiology is honored to welcome Dr. Brian McCrindle, who's joining us from Canada this morning, where he's a staff cardiologist and professor of pediatrics with the Hospital of Sick Children and the University of Toronto. His long career has been centered around preventative cardiology, lipid disorders and obesity, outcomes in congenital heart disease and Kawasaki disease. And over the many years, he's made many significant contributions to our understanding of all of the above. He's a principal investigator with the NIH Pediatric Heart Network, as well as the only non-surgeon faculty member, full member of the Congenital Heart Surgeons Society and co-director of the CHSS Data Center. He's the lead author of the 2017 most recent AHA guidelines for diagnosis and management of Kawasaki disease. And we're thrilled to be welcoming him to speak to us today about our current understanding of Kawasaki disease, its diagnosis and treatment, as well as some thoughts on its relationship with COVID-19 associated multi-system inflammatory syndrome. So please, let's welcome Dr. McCrindle.
Thank you very much. So I'm going to pull up my slides. So I feel very honored to be able to give this grand rounds to you. I've been working with Kawasaki disease now for 25 years. I would draw your attention to the photograph on the right. During the initial COVID lockdowns, a lot of people discovered different kinds of baking skills, and I made these macarons and decorated them up as COVID. So if anybody asks you where the COVID epidemic started, I cooked it up in my kitchen and it's delicious. So I have the following disclosures, and I would draw everyone's attention that the bulk of this talk is going to be an application of these 2017 guidelines from the American Heart Association, which I had the privilege to organize and lead this group. So the objectives are first to understand the complex etiologic working model of Kawasaki disease, to be able to diagnose Kawasaki disease, even in the presence of incomplete clinical criteria, to be able to acutely manage Kawasaki disease, including patients who are resistant to initial treatment, and then finally to understand the pathology driving long-term outcomes and the strategies we can undertake to prevent them. So Kawasaki disease was first described in 1967 and is now recognized as an acute self-limited vasculitis of early childhood that leads to coronary artery aneurysms in about 25% of untreated cases. At the time of Dr. Kawasaki's initial report of his clinical observations, he was not aware of the serious underlying coronary artery abnormalities that underlie this condition and lead to its major morbidity and contribution to mortality. It's also now known that Kawasaki disease has been reported worldwide and is the leading cause of acquired disease now in children in developed countries, replacing rheumatic heart disease. We understand the epidemiology indicating that the estimated incidence in North America is about 25 cases per 100,000 children below the age of 5 per year. However, in Japan, where this was first described, the incidence is probably more than 10-fold this. The highest relative risk, therefore, is in Asian children, especially those of Japanese ancestry, with a predominance towards males. KD affects predominantly, but not exclusively, young children. In North America, it is most common in the winter and early spring, so we really are in Kawasaki disease season right now. And environmental factors influencing the incidence are being increasingly described. A number of genetic factors have been implicated, both in terms of the susceptibility to Kawasaki disease, but also increased risk of coronary artery aneurysms. These are some of the more common genes that have been identified, and of note, they all have a relationship to inflammatory pathways. I've highlighted the ones in blue that are also associated with an increased risk of coronary artery aneurysms. Some of these mutations have led to novel therapies which may be more specific to Kawasaki disease. We also think that Kawasaki disease is initiated by either an acute infection or some sort of trigger. We know that patients manifest a response to a classic antigen that seems to be protective against future exposure in most patients. Studies of pathology have noted intracytoplasmic inclusion bodies in the bronchial epithelium and other cell types in patients who've died of Kawasaki disease, and these contain RNA and may suggest the presence of a novel virus. The seasonality of Kawasaki disease has been linked to tropospheric wind patterns over Japan emanating from China, which may transport an agent that, when inhaled by genetically susceptible children, which is the children of Japan, triggers this immunologic cascade, which manifests as Kawasaki disease. Early studies of the immunology of Kawasaki disease tended to favor it being triggered by a superantigen, but subsequent studies have favored a more canonical response to a conventional antigen. I have a research group that has tried to put many of these things together using both administrative data, since Canada has a universal healthcare system, and so our data is population-based, and linking it with climate data and data on infections. And this is sort of our working model that we have derived from the data analysis that we have done. So first we start with a genetic predisposition, either through genetic modulators or through natural development or maturation of the immune system, which explains the age. This immunologic system is then acted upon by environmental modulators with low exposure to common antigens, perhaps leading to low tolerance to immunologic challenge, such that when either an immunologic trigger or an allergic trigger is encountered leads to these patients having exaggerated response, which leads to the presentation of Kawasaki disease. We further refined these factors such that we can identify those factors associated with an individual's risk of developing Kawasaki disease, but also explain the global distribution of the epidemiology of cases. And these include genetic contribution, impact of factors that influence the immunobiology, and then thoughts about the environmental trigger. And when we looked at the global model, using these four factors, the population proportion of East Asian descent, the distance from Northeast China, the proportion of the population living in urban settings, and the concentration of fine particulate matter air pollution in a given region, we can predict the incidence of Kawasaki disease in that region with a model R squared of 0.88, which is very, very high. Children don't often die of Kawasaki disease, so we don't really know a lot about the underlying pathology. A group from Chicago did amass a catalog of pathologic specimens, and were able to define what this underlying sequence of events that that are related to the vasculopathy. In the acute stages, the pathology is characterized by an acute necrotizing arteritis. And then in the subacute and chronic phases, there may be underlying vasculitis that incites a luminal myofibroblastic proliferation, or LMP. In addition, thrombosis can contribute to changes in the vessels, and we're always looking for a contribution of traditional atherosclerotic cardiovascular risk factors. And that leads us to this model of the natural history of Kawasaki disease. You can see in the upper part of the figure that the vast majority of patients will either have no coronary artery changes or mild dilatation that's transient and does not represent structural changes to the vessel. However, in the presence of necrotizing arteritis, under hemostatic factors, it leads to aneurysm formation. These aneurysms formation, more in the acute phases, can be complicated by acute occlusive thrombosis, which can lead to myocardial infarction, or subsequently recanalize, or the vessel cannot have thrombosis but develop this luminal myofibroblastic proliferation with thickening of the wall. And through both of these processes, the vessels may achieve a normal luminal dimension. However, the vessel is definitely not normal, and the processes that I've outlined can progress and lead to complex stenoses and ischemic heart disease. So I'm going to weave a case through this to show you how the guidelines related to diagnosis and management can be applied to a specific case. So this is a 5-month-old male infant with 6 days of fever who has non-purulent conjunctivitis, red, cracked lips and tongue, erythema of the palms and soles, but had no rash and no adenopathy. He had additional symptoms of cough, rhinorrhea, and vomiting, and had been seen in a outpatient practice and felt to have a possible strep throat, and was placed on amoxicillin, although no swab was done. Of note is that the patient had an older sibling who had a history of an upper respiratory tract infection, and the family had had the carpets cleaned in the house 2 weeks ago. So to diagnose Kawasaki disease, we still rely on classic clinical features that have not changed since Dr. Kawasaki's initial description of them. Fever for at least 5 days, plus at least four out of the 5 features that I've already mentioned are required to make the diagnosis of classical or typical Kawasaki disease. However, about 25% of cases will not have sufficient criteria and can be deemed incomplete Kawasaki disease. Part of the problem is that some of these features may resolve before the patient presents to clinical care. The features most commonly lacking include cervical lymphadenopathy in 90%, rash in 50%, and extremity changes in 40%. Lack of clinical features is most prevalent in patients who are very young, usually less than a year of age, for which 45% of cases may be incomplete. However, the presence of coronary artery abnormalities confirms the diagnosis of incomplete Kawasaki disease. Additional non-cardiac features are somewhat non-specific but can contribute information to the diagnosis. During the convalescent phase, a characteristic pattern of peeling, starting at the nail beds and the fingers and the toes, together with the presence of very high platelet counts, often up to 1 million, are felt to be somewhat diagnostic of someone having had Kawasaki disease, although this is being challenged now in the presence of MIS-C with COVID-19 infection. Laboratory values are also useful in helping to differentiate patients who possibly have incomplete Kawasaki disease, and therefore here is a laboratory workup, and we can incorporate these criteria into making a decision as to whether someone has sufficient evidence that incomplete Kawasaki disease is present and therefore merits treatment. So the presence of inflammatory markers with 3 or more suggestive laboratory findings or a positive echocardiogram is sufficient to make a diagnosis of incomplete Kawasaki disease in a patient with insufficient clinical criteria. So our 5-month-old male infant with incomplete criteria actually had 5 of those lab criteria with a very high CRP and ESR, anemia, high white count, elevated liver enzymes, and a low serum albumin, and thus would meet criteria for having incomplete Kawasaki disease. But there are some things that come up in the differential diagnosis that are much more common than Kawasaki disease. Viral infections such as adenovirus or enterovirus or staph or strep toxin mediated diseases can have similar features to Kawasaki disease. Often the kids are treated with antibiotics presumptively, and this can bring into the differential drug hypersensitivity reactions. Measles is also something to consider. And we've had a number of cases, although rare, who presented with Kawasaki-like features who went on to actually have systemic juvenile idiopathic arthritis. And rare causes include infections such as rickettsia or leptospirosis. But I think we now have to include in the differential the multi-system inflammatory syndrome in children associated with COVID infection. There are certain characteristics of patients that would lead to a higher index of suspicion that they might have Kawasaki disease. Very young infants, less than 6 months of old, who have prolonged fever and irritability, or unexplained aseptic meningitis, or prolonged fever with unexplained or culture negative shock, or cervical lymphadenitis that isn't responsive to antibiotic therapy, or patients with retropharyngeal or parapharyngeal phlegm that's unresponsive to antibiotic therapy should be suspected, have a lower index of suspicion for having Kawasaki disease. So now moving on to acute treatment, standard therapy has actually been standard for quite a while. Therapy should be initiated within 10 days of the onset of fever, and includes an infusion of intravenous gamma globulin at high dose of 2 grams per kilo, infused over a duration of 10 hours. In addition, anti-inflammatory doses of aspirin have been used in the past. However, recent studies have shown there's no evidence that the addition of high-dose aspirin reduces the risk of coronary artery complications, and therefore many centers have now instead opted to directly go to low-dose aspirin for its anti-platelet effect. Of note is that IVIG is generally not administered to patients beyond the 10th day of illness unless they have ongoing fever, very high inflammatory markers, or coronary artery abnormalities or presence. Of note is that when you're monitoring response, to IVIG therapy that the ESR may be artificially inflated. Now, a certain proportion of patients, approximately 10 to 20%, may not respond to that initial infusion of IVIG. We define IVIG resistance as persistent or recurrent fever at least 36 hours and less than 7 days after completion of the first infusion. It is associated with an increased risk of coronary artery abnormalities, but the treatment and the definition of it has been somewhat variable from paper to paper. The observation may be confounded by some patients having concomitant infections that are associated with fever. And therefore, the selection and effectiveness of additional treatment is not particularly evidence-based, as are various risk scoring algorithms used to determine if a patient might be at risk for having IVIG resistance. It would be useful if we could predict who is going to be resistant to IVIG, because we could then institute additional therapy up front. So our 5-month-old male infant, is he at risk for higher risk? Is it at higher risk for IVIG resistance? Well, as I mentioned, the risk scoring systems don't work well, but he does a number of features from these systems that may suggest so. He's very young. He has high liver enzymes, higher CRP, and a higher neutrophil count. What is he also at risk for higher risk for coronary artery aneurysms? Again, the current systems don't work very well, but he has a number of risk factors, including young age, low serum albumin, higher white count, and lower hemoglobin. So if we were to, given his risk, intensify his primary therapy, what should we be adding? So there have been studies that have looked at adding a single dose of corticosteroids, which have not really had any effect. And then in Japan, the RAISE trial advocated and studied a prolonged course of steroids, which did show some benefit. Studies of infliximab and etanercept and cyclosporin have been somewhat equivocal in their ability to further prevent coronary artery involvement. So our 5-month-old infant with incomplete KD was given IVIG and low-dose aspirin. His fever initially went away, but 12 hours post-infusion, his fever increased, indicating that he had a partial response. Of note, his NP swab was positive for influenza A, and given the risk of Reye's syndrome associated with influenza infection, he was switched from aspirin to dipyridamole. So how do we then manage his IVIG resistance? So not a lot of these options are evidence-based, but many would advocate just retreat with an additional course of IVIG, or use IVIG together with steroids. Infliximab has also been advocated, although the evidence is less robust. Additional options, if the patient is not improved with one of those three options, is to consider cyclosporin, anakinra, cyclophosphamide, or even plasma exchange. So our 5-month-old male infant was given a second dose of IVIG and resolved his fever. His other clinical signs were improved. He had a moderate drop in his hemoglobin, and certain preparations of IVIG are associated with hemolysis. His platelet count was noted to be increasing, and he had an initial echocardiogram that had been performed after his first IVIG dose had been completed. Of note, it's very important that you don't delay treatment pending the availability of an echo. So on his first echocardiogram, he was noted to have normal ventricular function, some mild mitral valve regurgitation, and a small amount of pericardial fluid. And these are the absolute luminal dimensions of his coronary artery branches, which were described as being abnormal, which wasn't very useful. So if you are going to assess the coronary artery abnormalities, in addition to qualitative assessment, You also need quantitative assessment, but not just the absolute values. They need to be normalized for the body size of the patient as Z scores. And then you can classify based on these Z scores. There are a number of different classification systems available, indicating from different populations, different um, statistical methods. And in addition, there is a new Z-score formula system that came from the NHLBI Pediatric Heart Network from Leo Lopez, was the leader of that study, who is now in cardiology at Stanford. So the original way of classifying coronary artery abnormalities from the Japanese Ministry of Health criteria were solely based on the absolute dimensions, which did not take into account that our patients come in all different shapes and sizes. So we attempted to create a categorization that was more based on Z-scores. And so, and this is the correlation between the categorization based on absolute dimensions versus the Z-scores. And from this, we were able to define no involvement as having always a Z-score less than 2 or 2 standard deviations within normal. Dilatation only was 2 to 2.5, or if the patient was initially less than 2, but during follow-up became more normal by at least 1 standard deviation. A small aneurysm was indicated by 2.5 to 5, medium 5 to 10, and a large or giant aneurysm of 10 or greater. Of note is that our patients tend to be very small, and small measurement errors in small patients can make big differences in Z-scores. In addition, we have to take into account that some patients may have either dominant right or left coronary artery systems, which may influence their coronary artery dimensions and complicate the assessment of normality. So when we took our patients' absolute dimensions and normalized them as Z-scores, we can see that all of his coronaries are significantly increased in size, and that he probably has a medium to large aneurysm in the left anterior descending and a medium to large aneurysm in the right coronary artery. And this corresponds to the qualitative statements that were made in the echo report. So given that our patient is now has a significant coronary artery involvement, we have 2 questions. So should the patient receive anticoagulation? And then should the patient receive additional anti-inflammatory therapy? So the echo was repeated 5 days later after that second course of IVIG was completed. The CRP had come down. And on his second echo, he showed significant progression of his coronary artery involvement, such that the aneurysms in the left anterior descending and the right coronary artery now had Z-scores of 17 plus, hence giant aneurysms. And I've noted on the qualitative comments, he had a non-occlusive thrombus present in the distal LAD aneurysm. He had, however, normal ventricular function and no ECG changes. So it's important to recognize that the leading cause of early myocardial infarction is failure to escalate thromboprophylaxis in anticipation that whatever you're seeing is going to get worse. So he should have, at the first echo, actually been started on anticoagulation. However, once this was noted on the second echo, he was started on low molecular weight heparin. It was decided, since the clot was non-occlusive and he had no ischemic changes, that he did not need to be treated with thrombolysis, but he was given a dose of abciximab and started on a course of steroids to further reduce his level of inflammation. It's noted that selected patients with extensive and severe involvement, multiple vessels involved, and multiple aneurysms in a single vessel, or who have a history of thrombosis, which he does, may require triple therapy with aspirin and clopidogrel as dual antiplatelet agents in addition to anticoagulation. So now we move into the long-term management. So as I mentioned, the majority of patients will have normal coronary artery dimensions throughout their course. These patients are treated with low-dose aspirin and will have echoes done at 1 to 2 weeks and 4 to 6 weeks. And if all of the echoes have been normal, the aspirin can be discontinued, the patient can be counseled about healthy lifestyle, and then discharged from further follow-up. However, there is room in the guidelines for some centers, if they so wish, to continue to follow the patients for up to 1 year. For patients who have dilation of the coronaries only, they're recommended to have aspirin together with echoes at 1 to 2, 4 to 6 weeks, and 1 year, at least until the dilatation has resolved. When that happens, you can stop the aspirin, counsel the patient, and discharge them. For patients with aneurysm, the management, the long-term management is much more complicated. Medical management and follow-up is based on both where the coronary artery was, the degree of coronary artery involvement at maximum, and then where they are currently, and as defined by Z-scores. So our patient is now 3 years of age. At 18 months of age, his low molecular weight heparin was switched to warfarin, and it's been a nightmare in a very young child as he is very active. He remained on aspirin and clopidogrel, so he was still on triple therapy, and he fortunately only had some minor bleeding complications. He had an MRI at 2 years of age, which confirmed the presence of the coronary artery aneurysms seen on echocardiography. But since on echo, you only see the proximal segments, an additional aneurysm was seen in the distal circumflex. He also was noted to have small aneurysms in the axillary and femoral arteries. For patients with severe coronary involvement, they can actually have involvement in other medium-sized arteries and vascular beds. He had normal ventricular function and no wall motion abnormalities at rest. He had an adenosine stress, which showed no stress-related wall motion abnormalities, and he had no late gadolinium enhancement and hence no scar. And these are the echo findings of where his Z-scores went to on his echo at 3 years. And you can see that his left anterior descending Z-score at maximum was 22.4 at 4 weeks, but had reduced by 3 years to 8.1. And the right coronary artery aneurysm had a Z-score of 19.9 at maximum and had reduced to 8.5. So now medium aneurysms. He had no thrombosis, normal ventricular function, and no ECG changes. So for this patient whose absolute dimensions and Z-scores have decreased, what does this mean? Can we adjust or reduce his thromboprophylaxis? Should he be on a beta blocker or a statin? How frequently should he be seen now, and what tests should be ordered? And then what's his long-term prognosis? So risk stratification is based on where Z-scores go. If the Z-scores are increasing, usually that is happening very early and reflects the impact of necrotizing arteritis, which acutely can put the patient at risk for rupture, thrombosis, and myocardial ischemia. During follow-up, we're looking at decreasing Z-scores, and this reflects the impact of inflammation, proliferation through luminal myofibroblastic proliferation, and the effect of thrombosis. So if you're going to calibrate the risk of event related to thrombosis, stenosis, or occlusion, we need to take into account where they were at maximum and then where they are right now. And just to remind you that this is based on what we understand to be the natural history of the pathology of the coronary artery involvement. So sometimes when we say that the dimensions have decreased, we call this regression, but what does regression really mean? Well, the only thing it means is that the luminal dimensions, as we see on echo, have reduced in size and perhaps fallen now into the normal range. However, this is achieved through the processes of luminal myofibroblastic proliferation, laminar thrombosis along the wall of the coronary artery aneurysm, and perhaps occlusive thrombosis with recanalization. So a reduction in the luminal dimensions has the consequence of reducing the risk of thrombosis, but the proliferation increases the risk of stenoses and subsequent occlusion. We can define the natural, this is one of the first papers that defined the natural history based on the size of aneurysms using absolute dimensions and echocardiography. And you can see that for patients who had started with aneurysms that were 8 millimeters and above, which would be technically large or giant aneurysms, there was persistence throughout the period of follow-up. But that the smaller the aneurysm was at maximum size, the greater the likelihood that they would achieve luminal normalization of the dimension and do so in a faster period of time. We actually looked at this now using normalized dimensions as z-scores, and again confirmed that the top line, which shows aneurysms greater than 8 millimeters, or actually this is freedom from events, that the patients who had small aneurysms or that non-giant aneurysms or non-large aneurysms had a complete freedom from clinical outcomes such as cardiovascular events. And we actually found that no patients who had an aneurysm that was less than 10 z-score had any risk of coronary artery events. So when we go to the guidelines now, clearly we have to classify patients. And our patient would be a patient who would be level 5, who had a large or giant aneurysm initially, that then now is decreased on echocardiography to a medium aneurysm. So he would be now currently in risk factor 5.2. We do, however, have to ever take into account additional factors such as the length and dislocation of aneurysms, the greater total number of aneurysms, greater number of branches affected, abnormal characteristics of the wall, and the presence of previous coronary artery thromboses. We can actually look at the caliber, the quality of the wall, the characterization of the wall by using things such as intravascular ultrasound, or more recently, optical coherence tomography, which can characterize areas of that luminal myofibroblastic proliferation and show the thickened walls. So when we make recommendations for long-term management, these are the things that we need to recommend. The frequency of cardiology assessment. Should we be assessing for inducible myocardial ischemia? The type and frequency of probably advanced imaging, medical therapy, including antiplatelet, antithrombotic, beta blockers, and statins, cardiovascular risk counseling, assessment and management, and then physical activity and reproductive counseling. So we came up with tables for, first of all, the monitoring that were calibrated to the current risk level of the patient. And so for our patient, if we followed that table across with a large aneurysm that decreased to a medium aneurysm, we would have to assess them every 6 to 12 months, do stress testing every year, perhaps do advanced imaging with CT or MRI, or even invasive angiography could be considered every 2 to 5 years, assess them for cardiovascular risk factors and manage them every year, promote physical activity at every visit, and provide age-appropriate reproductive counseling without any modifications. Now, what about medical therapy? So we can see that pretty much across all the risk factors that low-dose aspirin is indicated or reasonably indicated unless the patient had no involvement or resolved dilatation only. Only those patients with current or persistent larger giant aneurysms are reasonably indicated for systemic anticoagulation. Dual platelet therapy can be either added for high-risk patients or can replace systemic anticoagulation in scenarios where you might think that anticoagulation is too much, but aspirin only is not enough. Beta blocker is only considered in those patients who have large or giant aneurysms. And recently, we recommended that statin therapy may be indicated for any patient with significant coronary involvement, regardless of the degree of regression, mainly trying to tap into the pleiotropic effects of the statins. So for our patient who's risk factor 5.2, he should be treated with low-dose aspirin. Anticoagulation is now not indicated unless he has other risk factors. We can discontinue the anticoagulation and perhaps substitute another antiplatelet agent, such as clopidogrel. He's already on dual antiplatelet therapy. We would incorporate those additional coronary artery characteristics in making thromboprophylaxis decisions, and perhaps he could be started on empiric statin therapy and beta blockers. So where are we going right now with regards to our thoughts about long-term management? What's in the future? Well, newer novel imaging techniques are being developed to further characterize the morphology of the wall of aneurysms. In addition, we're able to do computer-based flow simulations that can define the effect of coronary artery changes on rheology that may reflect an increased predisposition to thrombosis. We can do functional assessment of coronary arteries, we can personalize risk, and we can look for new therapeutic targets, particularly the use of the direct oral anticoagulants coming into the armamentarium for thromboprophylaxis. And again, I mentioned statins for optimizing remodeling. So a lot of institutions may have one or two or a few aneurysm patients, and therefore it becomes very hard for any given institution to perform a study that would define outcomes and optimal management pathways for patients with coronary aneurysms. So in July of 2013, I started what has grown into the International Kawasaki Disease Registry with the primary aim to determine the prevalence, patient level, and medical management factors associated with outcomes of coronary artery aneurysms after KD. And our first paper was recently published, where we reported data from 34 institutions with 1,651 aneurysm patients, and defined that no complications were noted in patients who had Z-scores of less than 10 at maximum, that luminal dimensions normalized more quickly for small and medium aneurysms and less so for large aneurysms, and that those with Z-scores greater than 10 had a higher risk of cumulative events, including stenoses, thromboses, or major adverse cardiovascular complications. And these are the graphs that go with that, isolated down to only the patients with a maximal involvement of a large or a giant aneurysm. And you see there that there's a cumulative risk of both stenoses and thromboses, with thrombosis, the risk of thrombosis highest in the immediate acute period when the aneurysms are rapidly evolving. There may be a suggestion that within this category of Z-score greater than 10, we can further risk stratify, and that the larger the aneurysm, the greater the likelihood the patients are to develop both stenoses, or in particularly in the early acute phases, coronary artery thromboses. And all of the patients seem to have an ongoing risk of myocardial infarction or major adverse cardiovascular events. And a significant proportion of the patients will go on to require coronary artery revascularization, either with coronary artery bypass grafting or interventional catheterization procedures. And only a handful of patients will actually go on to require cardiac transplantation. So where are we at now with COVID-19? So the IKDR registry at the beginning of the pandemic, we're very concerned that with the focus on COVID-19, that patients with Kawasaki disease would either have missed or delayed diagnoses. So we submitted a letter to such to Journal of Pediatrics. And then almost at the same time, suddenly people were using the words COVID and Kawasaki disease in the same sentence. And with the emergence of the multi-system inflammatory syndrome associated with COVID, and I actually wrote an editorial suggesting that there were definitely differences, but more shared etiology and pathophysiologic aspects between the two conditions. So this is the advent of MIS-C is highlighted some challenges that we now face with Kawasaki disease. We recognize that the diagnosis of Kawasaki disease remains a clinical diagnosis, and you can't make a diagnosis of incomplete Kawasaki disease with no features, although sometimes this is now being done. The relationship to SARS-CoV-2 to KD is unclear, and should be noted that coronavirus variants have been implicated in the past in outbreaks of Kawasaki disease. The case definitions for MIS-C are somewhat vague at present, and however, the diagnosis must require documentation of some relationship to COVID-19. There is considerable clinical overlap between the features of KD and MIS-C, and there are many variants in between. We're now seeing patients who have no KD features and hyperinflammation, but no evidence of SARS-CoV-2, who are being labeled and managed as incomplete Kawasaki disease or MIS-C, sometimes even if they have a known cause for their fever. Comprehensive blood work is now being obtained on a larger proportion of patients with fever, including inflammatory markers, troponin, and NT-proB, and a large cross-section of those patients will also undergo echocardiography. Hence, we're defining a large population with subtle abnormalities that we don't nearly know the significance of. And in addition, there's some confusion about what constitutes cardiac involvement, in that patients may have subtle ECG findings, mild pericardial effusions, and cardiac biomarker lab abnormalities. Patients with fever and hyperinflammation only are being investigated for coronary artery abnormalities, and probably there again can have dilatation that's more probably fever related, but it's being taken as evidence of coronary artery pathology in support of a diagnosis of either MIS-C or KD. And hence, more patients, in addition to get expanded workup, are also getting expanded treatment, and steroids have been added to a lot of patients' clinical management. This confusion between Kawasaki disease, MIS-C, and fever hyperinflammation is going to contaminate any studies in the future of diagnosis, treatment, and outcomes. So I'd like to finally just draw your attention that every 3 to 4 years we have what I would consider the Olympics of Kawasaki disease, the International Kawasaki Disease Symposium, and this will be held this October. It was tentatively scheduled for Tokyo, but now has been moved to a virtual venue. And then finally, in conclusion, I'd like to draw your attention to anything that I haven't discussed you will find in this guideline statement. Thank you.
Thank you, Dr. McCrindle. I have a couple of questions I see in the Q&A that I can bring up here. Dr. Leibowitz is asking, what do you mean by canonical? I think that was in reference to antigen response earlier in the talk.
I'm not an immunologist, but I think it implies that the immunologic response is more reflective of a classic immunological response to an infectious agent.
And then he also asks, in what does IVIG do for Kawasaki's disease, and is there evidence that KD patients are immunodeficient?
So we don't know if KD patients are immunologic deficient, but as I mentioned, there are from genetic studies there are gene variants that imply that they may actually have a greater susceptibility. Uh, I'm not sure that it implies that they're immunodeficiency, but it does imply that they may have pathways that favor this unregulated immune response that happens to either the infectious or environmental trigger. Uh, People have also tried to do a long-term follow-up studies on Kawasaki disease patients, and there hasn't really been any increase, as far as I'm aware, any increased prevalence of immunologic conditions or autoimmune conditions.
And then the last question from him, do the excess platelets function normally, and what causes this thrombocytosis?
Yeah, we're not really sure what causes the thrombocytosis, but we're also seeing it now. Now that anybody with fever and elevated inflammatory markers is getting expanded blood work, we're starting to see thrombosis present in patients with MIS-C as well. It's much more impressive in the patients with KD, and there is some evidence that that the platelets are actually a bit dysfunctional.
We have a comment from Dr. Ken Weinberg. Great informative presentation. Why the specific involvement of coronaries in KD? And I think you answered this a little bit with your MRI findings, but are there sequelae of visceral vasculitis in other organs, or do we not know?
So the coronaries are most commonly, if so, Kawasaki disease is a vasculitis of medium coronary artery, medium arteries, and the coronary arteries are the first in line once you shoot blood out of the aorta. Um, and so they tend to be most commonly infected. I'm not really sure why it's the coronary arteries. We do see involvement in the splanchnic beds and the axillary and the femoral systems. We don't see involvement in the cerebral or carotid vessels, which is a bit unusual. You usually don't see involvement in other beds unless there is a sort of major involvement going on within the coronary arteries. The significance of the involvement in these other vascular beds is somewhat unknown. Most of the times, they tend to develop collaterals, particularly in the axillary and femoral systems. I'm not aware of any long-term sequelae with regards to involvement in the splanchnic systems.
One more comment: with the widespread sheltering in place and limited in-person school attendance, and model that KD is post-infectious multi-inflammatory syndrome, have you seen a decrease in the number of cases in KD in Canada diagnosed over the last 12 months?
So, I mean, this definitely does feed into our etiologic model of Kawasaki disease, where we do implicate environmental factors that influence immune modulation. So it's not just the fact that people have been sheltering in their homes. That's led to changes in lifestyle. Kids are less active, and they're usually not eating a good diet. They're changing their levels of adiposity. They're changing their levels of fitness. But one of the things we've also seen in the pandemic is a reduction in air pollutants. And so some of these factors may actually play into maybe even a reduced incidence of KD. We haven't been seeing a lot of KD. What's happening in our typical Kawasaki disease season is we're actually seeing more and more patients with MIS-C. And at the beginning of the pandemic, we were calling patients MIS-C, who I'm I'm not really sure they had MIS-C, but now these patients definitely fit all of the criteria for having MIS-C and do have, and the majority of them do have significant myocardial involvement, not necessarily coronary artery involvement. They develop an inflammatory myocarditis.
Is there any evidence of the new COVID variants carrying higher risk of MIS-C or specifically cardiac involvement? And how long should patients with MIS-C be exercise restricted in your opinion?
So, the variants of so one of the things that we've known, because we've been tracking MIS-C, and the International Kawasaki Disease Registry is an international registry that is retooled to collect information on acute KD and MIS-C patients and everything in between. And we do have connections with investigators worldwide. And one of the things that's very clear is that in Asia, they just have not been seeing MIS-C throughout the pandemic. They are starting to see a handful of cases now. It's really, MIS-C first cropped up in Europe and on the East Coast of the US. And what people are thinking is that, when the virus was transported from China and Asia into Eastern North America and Western Europe, that there was probably a mutation that made the virus capable of producing this delayed inflammatory syndrome that we see as MIS-C. I am not sure how the current variants that people are reporting within our population are going to play out in terms of MIS-C. Time will tell. Everything is evolving. What we say today may not be true tomorrow. And then what was the second part of the question?
How long should MIS-C patients be exercise restricted?
Yeah, so that's very controversial. So the IKDR, last week we just had an open webinar. We invited experts who have contributed to some guidance regarding return to play for patients who've had MIS-C. Theoretically, if we find ourselves having to evaluate from a cardiologic perspective every patient who has MIS-C, it's going to swamp the healthcare system. So there has to be, and we're probably wind up seeing a lot of patients who aren't at risk for anything. So the recommendations are really starting to come down on trying to figure out which of the MIS-C patients are really at risk for events related to physical activity. And I think patients who've had decreases in ventricular function noted on echocardiography, or significant arrhythmia noted on ECG, or presence of different types of heart block, or patients who have any cardiac symptoms are the ones that probably merit further investigation before they return to play.
I know it's 9 o'clock. I'm going to keep going with a few more questions if that's okay, but thank you everyone for joining us. And I'll finish these few questions if that's okay with you, Dr. McCrindle.
Sure.
Would you expect to see potential coronary artery thrombosis in these MIC patients?
So coronary artery thrombosis in the Kawasaki patients is driven by, the hemodynamic effects of the aneurysm related to stasis and changes in shear wall stress, but also to endothelial issues, which render the vessel more prothrombotic and antifibrinolytic. And that's why the risk of thrombosis may be highest during the acute illness. We don't know how that plays out in MIS-C because we don't actually know what the pathology is in the coronary arteries, or actually even in the myocardium, and whether they actually have acute necrotizing arteritis or not. However, in the MIS-C patients, we do know that they can have significant coagulation abnormalities that are very prothrombotic, and there has been recommendations regarding the need for thromboprophylaxis in MIS-C patients. So I'm not aware of coronary artery thrombosis in a MIS-C patient, and mainly because I don't think their coronary cardiac involvement is more myocardial and less likely to be a coronary artery. That being said, there are patients that have had significant coronary artery aneurysms. When they follow the patients, however, the aneurysms tend to regress much more quickly than those noted in Kawasaki disease. So you wonder if it really is acute necrotizing arteritis or just extreme dilatation.
Sada asks, how do you approach myocardial ischemia assessment in infants with giant aneurysms? Do you stress MRI them? And in older patients, do you have a preference with regards to stress echo versus stress MRI?
So, so in infants, they tend to be, infants tend not to be at risk for coronary artery stenosis. They're really at risk for thrombosis. So testing for ischemia, testing for stenosis is not really that essential. If you are going to do it, we do it with MRI with adenosine stress. For older patients, we actually have exercise stress echo, where we're using actual normal exercise to stress the patients during echocardiography and looking for wall motion abnormalities. We still alternate that with MRI occasionally, because MRI actually gives you the opportunity to look at the coronaries right to the apex of the heart, gives you the opportunity to look at the myocardium and for any evidence of scar.
Just a couple more. How does the coronary inflammation that you mentioned due to fever factor into return to sports in kids with history of COVID infection but no cardiac symptoms, no cardiac manifestations?
Yeah, that's hard to know about because, as I mentioned, it's hard to know what findings are real. I'm always looking at ECGs and deleting a lot of stuff that I know is just normal findings. And the same might be true of the coronary arteries. We certainly know that anybody with coronary artery dilatation in the Kawasaki world really isn't at risk for anything in the long term, and those patients are discharged. If the dilatation is related to fever, which may be the case in the MIS-C patients, and that's been documented that the normal values in febrile children may be a bit different than those in afebrile children, then it probably has no impact on prognosis and maybe will have no impact on decisions regarding return to play.
And then final question, do you see a role for patient-specific blood flow simulations in MIS-C, perhaps to compare hemodynamic conditions to Kawasaki disease?
Yeah, so we actually at Sick Kids collaborated with Alison Marsden's lab at Stanford and did some very interesting work that defined some of the characteristics of aneurysms that may result in flow abnormalities that may predispose to thrombosis. It was a very small number of patients. The flow modeling is very labor intensive, as the folks in Allison's lab will tell you. So it's not quite ready for prime time, but there are emerging technologies where more of the simulations can be automated. And hopefully in the future, those can be incorporated into the long-term management and prognostication for the aneurysm patients.
That was actually Allison's question as well.
Oh, I hope I answered it correctly then.
Ringer. We brought in a ringer. Thank you so much, Dr. McCrindle. This was really an amazing overview, and appreciate the updates in terms of COVID, which is such a moving target. And thank you, Dr. Patel. Great job moderating the questions and bringing Dr. McCrindle to us. So thank you all very much for joining us. Have a great rest of your day and weekend, and we'll see you next Friday.
Great.
Thank you.
Thank you.
Bye-bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.